I want to thank this panel of witnesses. I also want to thank the previous panel of witnesses for coming here, for telling your stories, and keeping this front and center. We have to do that. With 0 FDA-approved medications for people who are suffering from long COVID, we just know people are suffering, and we have to increase the sense of urgency. I want to ask a couple of specific questions. As several of our witnesses today have noticed, it's vital that we continue to support research into our long COVID to better understand, prevent, and treat the disease. Congress has previously allocated $1.15 billion to fund NIH research on long COVID through a multi-pronged research network. However, I know that NIH has received critical feedback regarding its approach to this research, including the fear that it may not deliver any meaningful treatments to people suffering from long COVID. So I want to ask a couple of you to describe any concerns you might have with the NIH Recover program and highlight the possible opportunities for oversight and accountability within this program so that the NIH can better respond to the needs of patients with long COVID. And I want to add just a little bit to, Dr. Harkins, you talked about one approach is to looking at clusters, since this is multi-system. On the other hand, Dr. Alali, you talked about an institute for a greater number of infection-associated chronic illnesses that are complex and multisystemic in nature. And so it's kind of like you're taking it apart, you're putting more together. I just want to hear a little bit more about where you would take that. So Dr. Harkins and Dr. Alali.
Thank you. I think the Recover initiative is really trying to gather data and follow patients and really understand the disease. We want to be able to do treatments, and the treatment trials are taking a while to get going, yes. But the problem is one treatment isn't going to be available to fix everything, right? So all of these patients, we need to find out, well, what is driving the post-exertional malaise? What are the drivers for the respiratory and the cardiac complications? And then how can we devise research treatment plans for both of those? Because doing one thing and then having everybody join in, you're not going to see a result, I think. You have to have it very clarified for your specific patient population to see a benefit, is my feeling. That's going to take time, unfortunately, and that's what everyone is frustrated with.
Right.
I think the major question that we need to really solve is like why acute infections that we've trivialized for centuries. For centuries, we trivialized acute infections. Why acute infections in some cases lead to chronic disease? I think this pandemic is telling us, it's giving us really clues that, SARS-CoV-2 infection in most people, they do just fine, but some people succumb to long COVID. And then we look back in the history books, it actually happened after the flu. It actually, look at the MECFS, it's also thought to be driven by a viral illness. So I think the solution here is to try to really more deeply understand why acute infections lead to chronic disease. This requires really a comprehensive approach to really understand the mechanisms of why viruses that actually produce acute infections lead to chronic disease, understand the epidemiology, and also dissect therapeutic pathways. This really requires an all-hands-on-deck situation and a really a broad, comprehensive approach, interdisciplinary approach that should be solved, in my view, in the form of a new institute to tackle this issue. This will not only help you address the issue of long COVID, will also help us solve the puzzle of MECFS and all other infection-associated chronic conditions that have been ignored for decades, and help us prepare for the next pandemic. So one certainty in life is that we're going to be hit with another pandemic. We just don't know if this is going to be 5 years from now, 10 years from now, or 30 years from now. And it is important that we learn the lessons from this virus today to really face the rough waters of future pandemics. We would be all in failure if our children face a future pandemic and get hit with another long virus, 2030 or something, and they don't know how to treat it. That would represent our collective failure, and we really need to understand this now. And I think this is really, the time is now to understand infection-associated chronic diseases.
Thank you. I ran out of time for my question for Dr. Walker, but maybe I'll stick around and see if we can get another round.
Senator Cassidy?
Oh, thank you. Oh, my goodness. All right. So last year, we came together to provide $10 million in new funding for the Agency for Healthcare Research and Quality's patient-centered coordinated care for those living with long COVID, including new care models. I was proud to work with colleagues to continue this funding in our proposed Senate fiscal year 2024 bill. And I certainly want to work with our colleagues in the House to get this over the finish line. But Dr. Walker, can you talk about the importance of that AHRQ funding for long COVID and the gaps that would exist without it?
Yeah, thank you so much for that question. Thank you so much for advocating for that funding. I think it will be really essential in being able to expand the care that we provide to long COVID patients. So just to give a context, it is a multisystemic, complex disease, and primary care physicians at this stage are unprepared to manage this novel disease. It's an extensive workup for these patients and labor intensive. So these patients, as you've already heard, are oftentimes passed back and forth between subspecialists because of this multisystemic nature. And I've heard of patients seeing 30 subspecialists before they make it to a long COVID clinic. Yeah, that's absolutely true. And so there these extensive diagnostic workups that come with this as well is burdensome for the patient, burdensome for the healthcare system, and long COVID clinics are equipped to see these patients. The problem with that is we're rare. Many of us are closing doors, so the clinics are dwindling. So having this support is really important, especially since we receive these referrals and we become pretty saturated in our clinics to be able to see these patients. So this initiative is a 5-year initiative that funds 9 long COVID centers of excellence across the U.S. So it has a demographically distributed population. And what we're able to do with it is really expand care. So we're able to hire additional staff, care coordination staff. So it's really a person-centered, coordinated care model. We're very interested in the patient voice and have patient advisory committees. We are engaging with the community and community allies. So we know what the community feels about long COVID, how we can increase community-based referrals, and that we're meeting the needs of the community. And it also includes a component where we have an iterative evaluation component, again with the patient voice, so that we can continue to improve these care models for long COVID and then hopefully guide policy. And then the last thing I'll mention is, because I mentioned the primary care physicians and just a lack of understanding of long COVID, there's a very robust plan in place to provide peer education through ECHO, through primary care roadshows, through webinars, and multiple education series. So we're hoping to eventually decentralize the care of long COVID in the long run. Again, if 20 million individuals in the U.S. have long COVID, they can't be cared for in only these long COVID centers. Yeah.
All right, Chairman, thank you so much. Let me, again,